Good morning and welcome to the San Francisco Interfaith Council online briefing for community and faith partners. In today's program, the San Francisco Department of Public Health Office of Overdose Prevention's Director, Dr. Jeffrey Holm, and San Francisco Department of Emergency Management's Director, Mary Ellen Carroll, address San Francisco's response to the fentanyl crisis. A special thanks. The San Francisco Interfaith Council online briefings are supported by a grant from MetaFund. Thank you. The important and ongoing work of the San Francisco Interfaith Council would not be possible without generous funding from congregations, corporations, faith-based social service agencies, foundations, judicatories, and supporters like you. Help us spread the word. Visit sfinterfaithcouncil.org to learn about SFIC programming and how to become a supporter. Follow SFIC on Facebook and Twitter, and subscribe to SFIC's YouTube channel to watch all of our virtual events. A bit of housekeeping. Today's program is being recorded. For audio and video, all participants are muted and without video to minimize distraction. To submit a question or comment, select the chat button at the bottom of your screen and send a message to Q&A. Questions will be forwarded to the host and answered, time permitting. To select closed captions, select the live transcript button at the bottom of your screen and click Enable Live Transcription. There's no time like the present for San Franciscans to prepare for changes in the virus by taking basic actions that can protect themselves, their families, and their community. The San Francisco Department of Public Health urges people to be ready for COVID by staying up to date on their vaccinations, knowing how to reach their doctor, keeping a supply of rapid COVID tests, keeping masks handy, planning ahead for a possible infection, and staying informed with trusted sources of information such as sf.gov/COVID. Now is the time to come together, San Francisco. Together we can stop Asian discrimination, bias, hate, and violence. The COVID-19 virus has no race or nationality. It is simply a disease. To report a hate crime, call the SFPD at 415-553-1133. And at this time, I'd like to hand the floor over to the Executive Director of the San Francisco Interfaith Council, Michael Pappas. Michael, the floor is yours.
Thank you very much, Trey. Good morning. I'm Michael Pappas, and on behalf of the San Francisco Interfaith Council, I want to welcome you to this week's online briefing for community and faith partners. San Francisco, like many big cities across the nation, is grappling with the devastating impacts of the presence of fentanyl in the illegal drug supply. After fentanyl-driven deaths spiked in San Francisco in 2020, the city took concrete actions to reduce the accidental overdose death rate. Dr. Jeffrey Holm, who oversees the San Francisco Department of Public Health's Office of Overdose Prevention, is this week's online briefing featured presenter. He joins us to discuss overdose crisis and the policies and programs that have contributed to a decline in overdose deaths for 2 consecutive years. San Francisco Department of Emergency Management Executive Director Mary Ellen Carroll will offer an assessment of street conditions in our city's vulnerable neighborhoods in light of the fentanyl crisis. As we begin this program, we are very, very blessed to have with us friend and colleague, San Francisco Interfaith Council board member and Minister of Celebration at Glide Memorial Church, my friend Marvin K. White. And it was intentional in inviting him because when we think of Glide Memorial Church, in the Tenderloin, Glide and its congregants and its community of faith are witnessing firsthand and engaging with, and I suspect some of the congregants are victims of this crisis. And in his pastoral role, Marvin, we thank you for being with us. Marvin will also read the interfaith statement that we read at the beginning of each and every one of these programs. Marvin, welcome.
Great, thank you so much, Michael. The interfaith statement. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we are invited to offer a prayer in this setting, it should be offered according to the tradition with which we identify. If we are invited to speak on a subject from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other that we might better understand the multiplicity of faith traditions in our city and in our world. No one's condition, no one's diagnosis, no one's illness is incompatible with love. No one's family of blood and making is incompatible with love. No one's hopes are incompatible with love. No one's sexuality is incompatible with love. No one's economic status, no one's gender, no one's addiction, and no one's recovery is incompatible with love. No one's life is incompatible with love. No one's death is incompatible with love. No one's afterlife is incompatible with love. No one's memory and no one's erasure is incompatible with love. Nothing they ate, nothing they did, nothing they said is incompatible with love. No one they loved is incompatible with love. No one they trusted, no one they forgot, or nothing they drank or smoked is incompatible with love and can keep them from God. Because God and God's dispersal and dispensing of God's love has always been saying, my children, my beloved are dying, and this must be the sign for you not to love less, but to love more. We must leave here knowing that as much as empire and capitalism and patriarchy seeks out the optimal opportunity to lace the ontology with pain, the pain with numbing drugs, and the numbing drugs with death, that there is a God, and that God comes to all of us through that last vein and that last inhale. We must believe to our spiritual core that no drug addict actually ever throws themselves into addiction. And no drug addict wants to live their life trapped in addiction. And if we look carefully, we will always see shame's or trauma's hand shoved into the back, or some society's foot in their path, tripping them up. Addiction is an opportunity to test the boundaries. And if addiction is anywhere near you, take the test. If they are laid out on the sidewalk, the answer is someone or something has pulled the rug from under them. Love. Love is always looking for the most optimal conditions and accommodations to show us how to care through crisis, to suffer with the suffering, and yes, to heal and recover with the afflicted. God contracts and expands the addiction, and the names given to them by their addiction all have new meaning. Everyone's name means that God is love, and love is radical, and radical love is unconditional and inclusive. Amen.
Amen. Amen. And thank you. Thank you for grounding us, but also thank you for this perfect segue into discussing a very difficult issue. And I wanted to say to both to Dr. Holm and to Mary Ellen, this program is unlike you going and presenting before a commission. We invite you here today so we can better understand and we can better be part of the solution. People of faith are there to offer a unique spiritual dimension of healing. And so in that spirit, we welcome you here today. I think it is, and we're going to get these two wonderful perspectives, a public health perspective and an emergency management and street condition perspective. I think it's impossible to talk about this issue without putting it in the context of COVID, because as I mentioned at the outset, the peak came in 2020 at the beginning of the COVID pandemic. And we were being applauded in San Francisco for leading the nation as a model in terms of our response to the COVID pandemic. Yet at the same time, we were being put under a microscope on a number of other social ills. And so in that context, we really need to be cognizant of the trauma we were going through as a city and as a nation as we discuss this issue. The other thing I would just mention too is that our particular interest, yes, a lot of these victims are in our pews, but We also are part of the solution in that the San Francisco Interfaith Council convenes the CEOs of the faith-based social service agencies in our city that are on the front lines and providing essential services to our most vulnerable residents in San Francisco. And our faith-based social service agency CEOs have a unique and vested interest in this. And so we look forward to your presentation today. So without further ado, Dr. Holm, why don't you begin, and then Mary Ellen, you will follow.
Great. Good morning, everyone. And thank you, Director Pappas, for the opportunity to really sort of be here this morning with my colleague, Director Carroll. Let me just pull up my slides here. But it really is a pleasure to be here this morning. And again, thank you for the opportunity to join you. Again, my name is Jeffrey Hom, and I work in the health department in the Office of Overdose Prevention. I spent the last 8 years in Philadelphia, but am from San Francisco and recently returned about 7 months or so ago. And so it's really been wonderful to be back. And so I really look forward to meeting you, working with you, learning with you as we approach this very challenging topic, just like Director Pappas just mentioned. So here's what I'd like to sort of cover over the next sort of few minutes. Say a few words about the magnitude of our crisis today. I'm going to say a few words about how we got here, because I think it's important to sort of remember sort of what has sort of happened over the last several years, because I think it does inform how we're going to approach this issue moving forward together. And then I will certainly end with what our response has been before handing it over to Director Carroll. But as you all know, we are in the midst of this profound public health crisis. This is a national crisis. The governors of several states have declared public health emergencies around overdoses and public drug use and deaths in the United States. This is a series of maps from the New York Times. And what it sort of shows is dating back from 1999 up in the top left-hand corner all the way through 2015. It's every county in the country. And areas in light blue are those with lower rates of overdose deaths. And those areas in red are areas with high overdose deaths. And as you can see, going from 1999 through 2015, just how much of the country becomes engulfed. How many, every corner of the country has been touched, by this crisis. This series of maps certainly ends in 2015, and unfortunately, things only sort of got worse, both locally and nationally. And that's sort of what this screenshot from the New York Times does show. This is now from 2021, and so it's even a little bit behind where we are today. But you can see that, in 2020, the United States had over 90,000 individuals dying of drug overdoses that year. Subsequently, it did get worse, as we know in light of the pandemic and sort of the increasing prevalence of fentanyl in our drug supply, that over 100,000 individuals died of drug overdoses in the United States in 2021. Well, how did we get here? How did we end up in this crisis where more individuals now are dying of overdoses in the US, which is above the peak of the HIV/AIDS epidemic, more than the peak of gun violence deaths, all of which are public health crises. I do not mean to diminish the role that violence has in our country, other public health issues, but I think this does sort of also put into perspective just how severe our overdose crisis is locally and nationally. So how did we get here? So the story is sort of a well-known one in terms of today's opioid crisis, really sort of being fueled by the overprescribing of prescription opioids, prescription pain medications, many of which you might recognize the names of on this slide here. Morphine, codeine, hydromorphone, fentanyl is on here. It is a very strong opioid analgesic that is used in operating rooms and in ICUs across the country. Hydrocodone is one of the more commonly known ones, also goes by the name Vicodin or Lortab, as well as oxycodone, which goes by the brand name Percocet or OxyContin. I bring this up because I think it's important to understand sort of what is our relationship with opioid medications in general, and how does that relate to fentanyl? Well, so opioids work in a number of different ways, but for their pain relief benefit, this is sort of what is shown on this diagram here. I won't spend too long on it, but I want to sort of point out here is that pain may happen, someone may touch a hot stove. We experience that pain by nerve signals going from our hand up into our spinal cord and up into our brain, where we perceive that pain. It quickly sends a message back down saying, withdraw your hand from that painful stimulus. Opioid analgesics interrupt this pathway. They bind to receptors in the spinal cord, block our sensation of pain as it may be going up to our brain and vice versa. Opioids, though, also work on a number of other parts of the body. And there are receptors throughout our body. The Greek names the Greek letters are here. And they're located in the brain, the spinal cord, in our GI tract or our gut. And here are the range of effects. I won't read through all of these, but it does cause everything from pain relief to respiratory depression or a decreased breathing rate. Euphoria, it can make someone sort of feel good. Sedation, decreased gut movement, physical dependence, etc. And this is a function of the fact that opioids interact with a number of different parts of our body. And as a result, it has many side effects. Some of the common ones are here. Constipation is the most common side effect of opioids, as well as dry mouth, nausea, vomiting, dizziness, and drowsiness, many of which do resolve over time with continued use. On the more severe end, opioids can cause overdoses. And this is certainly the topic of today and much of the work that I do in my office here. I know certainly something that Director Carroll thinks a lot about as well from an emergency management perspective. But on the more severe end, opioids do cause respiratory depression and overdose. Individuals who have certain conditions may be at increased risk, individuals who do not have a tolerance to opioids. Pre-existing respiratory disorders such as sleep apnea. We know that higher doses of opioids are associated with increased risk of overdoses, which is shown on this slide here, that the more milligrams of opioids someone might be taking, the increased risk of an overdose someone may have. And then combining medications and other drugs. Opioid overdoses can be reversed by naloxone, which is an opioid antagonist. It's sort of basically an antidote to opioid-related overdoses that can be used and have been used in emergency situations to reverse an overdose and to save a life. Now that I've talked about all of these sort of side effects, well, then why are these sort of driving our overdose crisis today? Well, a lot of it also has to do with the fact that opioids have a property that release a neurochemical, a transmitter in our brain that is associated with pleasure. This is sort of the feel-good neurotransmitter, as it's called dopamine. And it's released naturally in response to pleasurable activities, such as eating, socializing, sex. And the idea is that it's reinforcing behaviors that are essential for the survival of our species. We want to feel good after we eat, and so therefore we're inclined to eat again, ensuring that we maintain the sustenance to keep us going. But it's also reinforced, dopamine is also released in the presence of opioids. And so that is sort of what is sort of driving continued opioid use. We take an opioid, we might feel really good, and that leads us to take it again. And it's important to know that prescription opioids are chemically similar to heroin. So we know that there are all of these side effects, but they are chemically similar. So Vicodin, Percocet, and OxyContin are all chemically similar to the brand name heroin, which actually was, again, a brand name of a medication that was marketed by Bayer in the late 1800s and early 1900s, marketed as a non-addictive alternative to morphine. So this is where sort of the history is important, because we have seen this now play out more recently, is how has OxyContin been marketed as a non-addictive alternative to morphine. And this is sort of why this is all important too, is that we see these sort of relationships of the overprescribing of opioids with other sorts of unfortunate negative outcomes associated with opioids. So because of this relationship to heroin and the potential for overdoses, it's something that we think a lot about from the prescribing side of things as we sort of think about prevention efforts. So this is a graph from the CDC. These are national data. And what it shows are 3 parallel lines. And we infer then that these are related. The green line there are the sales of prescription opioids. The red line here are deaths involving opioids. And the blue line here are treatment rates related to opioid use. Because it really wouldn't make sense that deaths or treatment admissions would drive sales, we can kind of conclude that it's really the sales of opioids that drove this initial increase in opioid deaths and the need for treatment admissions for opioid use disorder or opioid addiction. One thing I want you sort of just to remember or think about in the context of this sort of graph here is look at the time frame for this. As you see this really steep rise in the prescribing, which again is associated with this rise in opioid-related deaths and opioid-related treatment admissions, spans from 1999 all the way through 2010. And it's relevant because of the next slide that I'm going to show here. This is now looking at heroin. And again, think about those two and they're related. They're chemically similar. What this shows here is the On the x-axis here are, is again, years. And so now we're having overlapping years from that previous graph. This one goes from 1993 all the way through 2007. And what it shows here in this solid line is the price of heroin. And so the price is falling at the same time that we have that increased rate of people who are being exposed to prescription opioids. Now, not everyone who misuses prescription opioids goes on to use heroin. In fact, very few do. But given how many individuals, how many million individuals across the country do receive prescription opioids in any given year in the 1990s, it is, there certainly are individuals who have made this transition. And they're doing so at a time when our heroin is becoming increasingly cheap in the country. So you have this sort of perfect storm brewing of individuals who are being exposed to prescription opioids who are now having access potentially to very cheap, pure heroin if they are seeking it. Again, not everyone does, but for those who may be making the transition from prescription opioids to heroin, it is increasingly cheap in the country as we sort of enter the early 2000s. The purity of heroin in the United States has actually been declining over the last couple of years, though, and that's because it's being replaced by an increasingly potent synthetic opioid that we all sort of know today now as fentanyl. So fentanyl is a synthetic opioid painkiller. It's 50 to 100 times stronger than morphine, meaning that very small amounts of it are enough to cause an overdose, even in someone who has some degree of tolerance to opioids. And that's sort of what's shown in these vials on the right here. Each of those vials is about 2 inches tall. And what it's showing is the amount of drug that's needed to cause an overdose in an opioid naive individual. And so there's not very much heroin in that vial on the left, but there's comparatively a lot less fentanyl, meaning that very small amounts of it are enough to cause an overdose in someone who may be unsuspecting, unknowingly be consuming fentanyl. It's increasingly shipped from overseas into the US, where it can be added to heroin and to other street drugs, often unknown to the person who is consuming them. This graph or this map sort of is from the DEA, showing sort of this route of where fentanyl is coming from, illicitly manufactured fentanyl, and how it arrives in the US. Much illicitly manufactured fentanyl or its precursors, the ingredients to make fentanyl, are being shipped from China directly into the United States or through Canada or through Mexico. So that then sort of tells the story of these 3 waves of the opioid crisis that we sort of hear people talk about it sort of in public health spheres. And it's sort of this relationship that our crisis today was fueled by the rise in prescription opioid overdose deaths that we see here. So this is again 1999, where the majority of our opioid deaths involved prescription opioids. It wasn't heroin, it wasn't fentanyl. But over time, we saw then the rise in heroin overdose deaths, which began around 2010 nationally. So you can sort of see this rise, this increase in the blue line here. This is heroin. And then really in 2013, you had this significant increase, beginning in 2013, the significant increase in synthetic opioid deaths, namely fentanyl, that has really sort of shown no signs of abating here. And so 2015, 2016, you sort of see just how steep this rise is, such that the majority of our opioid deaths today, locally and nationally, involve fentanyl. There is sort of what's being called a 4th wave of this crisis, in which the synthetic opioids, such as fentanyl, are being used at the same time as stimulants, such as cocaine or methamphetamine. So polysubstance use, this idea that people are using multiple drugs at one time, is increasingly common. And that is sort of the crisis in which we find ourselves today. And so now I'm going to sort of zoom in. My last couple of slides here in terms of setting up the rest of sort of my presentation here are around our local data. These are data, preliminary overdose death data from our Office of the Chief Medical Examiner, showing the number of individuals who died of drug overdoses in San Francisco in 2022. We did end last year, as you saw from the press release was sent out to this community last week, that we ended with 620 individuals dying of drug overdoses in San Francisco last year. And then it breaks it down, this graph breaks it down by type of drug. So 451 individuals, their toxicology was positive for fentanyl. Fentanyl is driving most of our overdose deaths in the city today. But it was followed by methamphetamine. 350 individuals had methamphetamine in their toxicology, followed by cocaine. 249 individuals had cocaine in their toxicology at the time of death. And these are not mutually exclusive. If you add these up, it exceeds 620, meaning that people have multiple drugs in their bodies at the time of death. The bottom here, in orange here, is heroin, and gray is prescription opioids. So it's actually very, very rare now. Less than 10% of all of our deaths today involve heroin or prescription opioids. It is in fact hard to find heroin in our drug supply today because it has been largely replaced by fentanyl. Overall, though, amidst sort of some of these tragic and very unsettling numbers, our overdose deaths have been declining actually now for 2 straight years. These are now overdose deaths specifically involving opioids, cocaine, and methamphetamine. So the numbers are slightly different from what I showed on the previous slide. But what it sort of shows here are deaths involving these 3 classes of drugs in San Francisco from 2014 all the way through 2021. So we peaked in 2020, the year that this sort of collided with the COVID-19 pandemic. But we have sort of seen slight declines over the last 2 years. And every decrease in overdose deaths to me is something still to be celebrated, is to be recognized, because that means that more and more individuals are still alive. They're able to be with friends or families, and they have not died. But we also cannot accept this as the status quo. This does not mean that our work is by any means done. These decreases are small, and it shows that we have a long way to go. More than 600 individuals are still dying of drug overdose in San Francisco every year, meaning that we have much more to do. And that's where I think, as I talk about sort of our strategies of how do we approach this, there is a lot to be done. And I look forward to working sort of with this community on how can we advance programs and policies that will help save more lives. These data are also now a little bit old, but I think I still certainly want to put it up because they have not changed significantly in 2022. These data are 2020 and 2021 data, but shows the distribution of overdose deaths in San Francisco. We certainly do have this hotspot, this cluster of overdose deaths that occur in the Tenderloin and south of Market. But if you look at this map, you can also see these little dots in every corner of the city, just like that series of maps that I started with of the country. We have overdose deaths occurring in every corner. Every community has been touched by this crisis. And what we sort of ultimately need as a result of that is a whole city approach, thinking about how do we support the communities in which drug use occurs, how we support communities who have lost individuals due to drug overdoses, or who are trying to support individuals in their community who have a substance use disorder. And then certainly we also recognize that profound racial disparities in overdose deaths exist citywide. So the graph on the left here shows this disparity in very stark terms. Our overdose death rate among Black African Americans is more than 5 times higher than the citywide rate, which is really profound. It is something that is being seen nationally as well, and it's something that has worsened amidst the COVID-19 pandemic. And just to put this in sort of a different way for locally, which I think is just thinking about this in different ways is helpful for me, is that Black African Americans today represent just 6% of the population in San Francisco, but 28% of the preliminary overdoses reported by our chief medical examiner in 2022. And I'll come back to this at the very sort of end of my presentation because it is something that we are really focusing on within the health department and the city of thinking about how do we address this disparity in overdose deaths that we do see. So in my last couple of minutes here, I'd like to now sort of take some time to talk about our response. But before I do, I've shown a lot of statistics over the last couple of slides. But I now want to say that these deaths are not just statistics. Is that thousands of San Franciscans have died from drug overdoses over the past several years, and every one of those deaths is a tragedy. Every one of those deaths is someone's son, someone's daughter, someone's friend, someone's colleague, someone's brother, someone's sister, and we mourn the loss of every one of those lives. And I think it also, for me, as I think about that, I'm a primary care doctor, and I sort of think about the care that I provide to every individual patient and what they mean to their community. And so this also sort of reaffirms for me, my commitment, our commitment to aggressively approach this as a public health crisis, because addiction is not a moral failing, and really lives can be saved by increasing access to the range of services that we do have in San Francisco. And the picture on the right is the picture of City Hall lit up in purple last August 31st, which is International Overdose Awareness Day, recognizing all of these thousands of San Franciscans who have died and the communities they have left behind. So that leads me to sort of our overdose prevention plan. What are we doing in response to this significant overdose crisis? Well, we have 4 strategic areas, and I will say before I go into each of these is that just because we've released a plan now does not mean that work has not been going on for the last several years in San Francisco. There have been champions, both in the health department, in our health systems, and in the community, who have been doing this life-saving work for years. And a lot of the plan has been built upon that, built upon the efforts here, built upon what we know are best practices to engage individuals who are struggling with substance use and substance use disorders, and ensuring that they are connected to the range of services that can help advance their health and support them in achieving their goals and making sure they do not die of an overdose before they have a chance to receive some of these services. And so here are our 4 strategic areas. It's to increase availability and accessibility of the continuum of substance use services, strengthen community engagement and social support for people at high risk for overdose, implement a whole city approach to overdose prevention, and track overdose trends and related drug use metrics to measure success and inform program development and change. I'm not going to go through all of these in detail over the next couple of slides. If you are interested, it is available on our website, where we have the plan available in English, Spanish, as well as Chinese. But I will touch upon a couple of these that I would like to share in terms of sort of from my perspective in the health department. The first of which is this continuum of evidence of substance use services and how strengthening this will save lives in San Francisco. So what do I mean when I sort of say this continuum of substance use services? It's really the idea that there are, just as there are many paths to addiction, there are many paths to recovery. That what works for one individual may not work for another. And so we really want to make sure that we have services available to meet the needs of individuals wherever they are in their stage of change, whatever their relationship to substance use is. So as you can sort of see on this slide here, you have individuals who may not necessarily be interested in cutting back on their drug use just yet. In the same way that individuals who smoke cigarettes may not be ready to quit, despite sort of knowing some of those risks associated with smoking cigarettes. And so individuals who may be in the more pre-contemplative stage, we want to make sure that we have services such as overdose prevention programs, syringe access sites available to help them still meet their health needs. And then you have individuals who are maybe contemplating making a change, and maybe cutting back in terms of how much they use. We want to make sure that we have low threshold counseling. We want to make sure that we have withdrawal management programs for individuals who are now preparing and who are taking some of those first steps to reduce or change how much they are using a substance. And then on the right-hand side here, we have action and maintenance. And we have some of the programs that we offer here of how can we make sure that individuals who are pursuing treatment, perhaps with a medication like methadone or buprenorphine, that we have services that are available to them to support them and to promote their recovery while being on a medication, or other sort of wraparound services that we want to provide to them to support them. And so this is sort of what we mean by this continuum of services, because change is incremental and people may move through this continuum at different points in time throughout their life, and as they may use different sort of substances. So with that in mind, sort of here are our goals as it relates to sort of the plan. They're to reduce fatal overdoses by 15% citywide by 2025, reduce racial disparities in fatal overdoses among Black African Americans by 30% by 2025, and increase the number of individuals receiving medications for addiction treatment by 30% by 2025. And I'll be happy to talk later on if there are any sort of questions about how we sort of set these and what they mean for us. But just sort of, I'll put this out there for the timing in order to just go through my last couple of slides here. But this is sort of what we are holding ourselves to. I am very hopeful that we will meet these ahead of our stated goals here. And if that is true, we will keep changing our goals to be more and more ambitious. But this is sort of what we have put out there with our first iteration of the plan that came out just in September. Here are a couple of the sort of where we're at right now and what we've done in the last couple of months as we ended 2022. 3,200 individuals were treated with buprenorphine in 2021, more than had been treated before in the city. Buprenorphine is one of 3 FDA-approved medications for the treatment of opioid use disorder or opioid addiction. In 2022, the office-based buprenorphine induction clinic treated 575 patients with the same medication, which was a 164% increase from the previous year. Last year, or 2 years ago now in 2021, we're waiting for the final numbers for 2022. We also had 2,700 individuals receive treatment with methadone, a very effective medication for the treatment of opioid use disorder. And our pharmacy has also expanded its hours and is now doing delivery of medications to help improve access. And wait times for treatments have declined in the city. We're also distributing a lot of naloxone into the city here. Naloxone, again, is that opioid antidote where it reverses the effects of an opioid, thereby reversing an opioid overdose. So this can be life-saving. And so you can sort of see here on the graph on the left here is that our distribution of naloxone has steadily increased over the last several years. More than 9,000 overdose reversals were reported in 2021. Over 2,000 people recently completed our overdose recognition and naloxone training in the fourth quarter of 2022 alone. And really this year, we are really focusing on developing new partnerships with SROs, the Entertainment Commission, and schools to really help provide more overdose education as well as naloxone, recognizing that this is very much a life-saving measure. But I want to end by coming back to some of the real challenges that we are also facing here as it relates to overdose prevention and addressing some of these racial disparities, is that it isn't just about naloxone. It isn't just about even increasing access to treatment. Is that there are a lot of larger social factors that set individuals in certain communities in particular, especially the Black African American community, that sort of compounded the risk that is experienced by these. These are larger social factors. We didn't come here to get to this point in the span of 1 year. This is built upon decades of unjust policies, institutional racism, redlining. There are a lot of larger factors that we cannot lose sight of as we sort of think about our overdose prevention efforts. Yes, we certainly want to bring in more naloxone. We want to be able to increase access to treatment for all San Franciscans, but we also must look at these larger sort of social factors that, again, compound risk in disproportionate ways. And until we also think about that, we think about the social determinants of health, we think about housing, we will not fully realize our opportunities we have to reduce overdose deaths in San Francisco, in California, and across the country. So with that, I'm going to say thank you for your attention and joining me and us today. Let me just sort of say that I am very excited to be back in San Francisco here after 8 years in Philadelphia, where I did have a wonderful community of sort of partners throughout the community to do this work with. And I'm very eager and excited to build up the same relationships and partnerships with all of you to really learn how can we think about this? How can our response be informed? How can I sort of learn from the way your communities are experiencing this crisis and work with you on addressing this on this together? So thank you again, Director Pappas, and I'll hand it back over to you.
Thank you so much. We're going to get another perspective now, and that is from the Director of the Department of Emergency Management, Mary Ellen Carroll. First, I just wanted to say to Dr. Holm, thank you. It was a comprehensive, informative, and understandable presentation that I know is going to be shared throughout our communities of faith as we move forward. Mary Ellen reminded me in the waiting room that tomorrow will be the 3rd anniversary, I believe, of the opening of the Moscone Center for the COVID Command Center. And I just want to say that, 2020 was quite a year. And especially for your department, Mary Ellen, I know that, you had to help us coordinate our COVID response, but that was the year that this was peaking in terms of deaths. And I know that you and your team see this every day on the streets. And so we're hoping to get a perspective from you as well at this point. So without further ado, the floor is yours.
Thank you, Michael. And thank you, Dr. Hom. That was really an amazing presentation and educational for me also. Tomorrow is not the anniversary of Moscone, that we opened Moscone in March, but it was the first official full activation of the Emergency Operations Center for coronavirus that would become a global pandemic. And so that was 3 years ago. It's hard to believe. In the meantime, we have been busy with COVID, obviously, but also with a lot of other crises that have hit our city. During COVID, we had, of course, crisis of homelessness, the fentanyl overdose and youth crisis. We had heat waves and fire and air quality, and we pivoted. Last time I was here, I think I was talking to you about the Tenderloin Emergency Initiative that we took on last year, a year ago, and then most recently our winter storm. So I just want to shout out to my team that is just, I don't know, the most selfless and tireless workers that I know, but many, many city workers who have dedicated, that's my cat, dedicated their really their lives to serving the city, including our partners at Public Health. So, my job at DEM is really, one of the big parts of my job is to work with the community and ensure that our response is community focused and equitable. It's one of the most important lessons from our COVID response, is to really include a lens of equity into everything we do. And we're still learning and still iterating that lesson. But, a lot of people may ask, well, why is the Department of Emergency Management involved in issues of homelessness or a public health crisis? And I think that's what I'm going to talk to you a little bit about today, what we do. So we were asked back in 2020 to take more of a coordinating role around street conditions. We had already been hosting the Healthy Streets Operations Center for several years. I think it's going on 5 years now. Really what we do in emergency management, we're conveners, probably number one. We bring people together, problem solve, we support, we help coordinate resources, and we provide assessment and evaluation into the work that we do as a city in response to whatever issue that we're dealing with, whether that is a happy thing like a Warriors championship parade or celebration, or whether that is a global pandemic, whether that is a major winter storm, or whether that's the crisis that we see in our street conditions. So Trey, if you want to just pull up the slides now, we can get started. I'm going to try to keep this a little short so that there is time for some discussion, and I probably won't run through all the slides, but just to kind of get started, I'm going to talk to you about these various teams. San Francisco Street Crisis Initiatives aim to provide the most compassionate care to people who are experiencing crisis in the street. And all of these initiatives include multidisciplinary teams that are responding to an array of behavioral health crises, wellness checks, and other crisis-related incidents. And fentanyl and substance use disorder absolutely is aligned through almost all of what we see on the street. So before I get into the details of what these teams do, I want to talk a little bit about the perspective of a person who is not in crisis. So that could be many of you or your parishioners, but the public in general. What does a person do when you see someone in crisis in the street? And I think this is one of the questions we get most. I know that we all feel helpless at times when we see people. We feel worried, we feel fearful, usually for the person experiencing the crisis, sometimes for ourselves in that environment. But right now, what I'm here to tell you, the best thing to do when you see someone in crisis and you're not sure what to do is to call 911. Our dispatchers are highly trained. They have been trained, especially with the implementation of these new programs and street teams, to assess the situation based on the information that a caller gives so that we can get the best resource in the fastest way to that person. Some people are hesitant to call 911 because they do not want police response, and we understand that. But what I want to share with you, and I hope that this gets out there, is that all of the programs almost that have been developed to provide an alternative to law enforcement are dispatched through the 911 dispatch center, which is part of my department. And so many times there may be they may determine that some of these teams would be going out there. It may be that an ambulance will need to be sent out because of the nature of the description of the problem, or in some cases, law enforcement would be sent, but that would, we have ways in which we are really trying to tease out if it's a behavioral health crisis, to not send law enforcement unless and only if there is a risk of life to that person or someone else. So, we're a leader. San Francisco is a leader in these developing these alternatives. And we're also we're on the front line of doing this in a way that is in common. So we are learning as we go, of course, also. So at this point, the other thing I just want to say about that is that there's also, oftentimes there is frustration that, perhaps someone calls, there's a response, a city response of some way, could be skirt, it could be a light ambulance, could be this. And then the person is there, they return, and there's not an immediate resolution. And the fact is that what I can tell you is that the city does not give up on people in crisis. Many folks, and as Jeff has indicated from a kind of clinical perspective, some of the ways in which addiction affects people, but there's a lot of other issues, behavioral health, mental health issues. It's not a one contact or one engagement and done most of the time. So our teams are out there building relationships, engaging people. And, unfortunately, it may take many calls before that person is on to the next step or to the next place. We have many tools in our pocket, but we also have many limitations. We cannot compel people into treatment unless they reach certain benchmarks for a 5150 or what have you, and not everyone meets those criteria, even though we as a layperson might look at a person and say they are not able to take care of themselves. So I just kind of wanted to put out there. I work closely with all of these teams from throughout the city, and I can tell you that the level of dedication and compassion and love is there, and we are iterating and trying to kind of move forward with the best of our ability. So I'm going to run through very quickly just the different teams, and then I'll stop, and then if there's questions. But I hope if we take one thing away is that the information that 911 is the access point for many of these crisis response alternatives to law enforcement response for people who are suffering the street. And I really want people to feel comfortable to call 911 if they see someone who needs help. So we'll move to the next slide. Let's just keep going to next slide, please. So street response team, this is the SCIRT team. This is one of the teams created as an alternate to law enforcement. There's two service components. They respond to an array of behavioral health, overdose, and wellness check concerns. And they also coordinate longer term people getting people from the rapid response into a longer term. There have been almost 14,000 calls to SCIRT that used to be handled by police that have now been handled by the street crisis response team. So I think that's an important data. The average time for them to respond is 17 minutes from when they get the call dispatched to them till they're on scene. Let's move on to the next slide, which talks about the street overdose team. So also known as SORT. This was created and launched in August of 2021, and it's an intervention for people with opioid disorder, and especially for those that have survived an overdose. They respond immediately to people who have had an overdose. And some of the support that they provide are, of course, naloxone, but also treatment medicine, supportive counseling, and getting substance use treatment. There's a second part of it, which is the post-overdose engagement team, which is we call POET, follows up within 72 hours after an overdose to kind of provide that support care, resources, and connection to treatment. Next slide. So the Healthy Streets Operations Center, this is the more longer term encampment resolution team that has been housed at DEM for the last 5 years, multi-agency. We have a team of social workers, clinicians, paramedics, street cleaning, and police officers who work together to provide services to people who are unhoused. We provide access to shelter, medical, behavioral health services, and other referrals. They had, again, these are the larger encampments that we go in, do some advance notice assessment. We come in with services and connect people. So from June 2020 to September 22, there have been about 1,200 operations, and over 10,000 clients have been engaged. Of those, about half of the folks engaged have entered into shelter or some sort of residential placement. And, some of the folks that we see in shelter, or some of the people we encounter, there's a certain percentage that are already in shelter and have returned to the streets while they have active shelter housing. A lot of that can be related to their substance abuse disorder or other behavioral health issues. And like we said, about half of the folks have declined services through HSOC. So that's the HSOC program. And we'll move to the next slide, talking about EMS6. So this is really for folks that are EMS6 is focused on people who are very high frequently use or dependent on 911 system for their services. And so the team really focuses on, meets those vulnerable folks where they are and tries to work with them more intensely to break this cycle of dependency on the 911 system with follow-up engagement, wraparound services, and linkages to other services. And then finally, for my last slide, I'll just talk about our community response team. So this is a new team it is a pilot program. It will really fill an important gap. So as I said, we've really been able to take a lot of the behavioral health calls off of from being dispatched to police, but we still have a high number of calls that don't have, that are very low level calls that mostly are related to people who are suffering from either substance abuse or homelessness. And so this will be a group that'll be a community staff's team that will be able to go out and respond to some of these low level calls. We are in the process, we're in the middle of that procurement process right now, and we hope to launch the team in March. So I will stop there and turn it back over to Michael. I just want to thank you again, Michael, for your partnership. And I want to thank this group. The Interfaith Council is always there for the Department of Emergency Management and for the city. And we are grateful for that.
Thank you. It's in our DNA and it's part of our core mission. Welcome back, Dr. Hom. And thank you, Mary Ellen, for your wonderful presentation. In the remaining 5 minutes, and I should tell you both, we've had quite a robust number of questions come into the chat. We're not going to be able to get to them all. I know that. What I will do, though, is send them to you for a response to those who asked. a question. The Black African-American population that has been impacted by this crisis has been 28% of the overdose deaths in San Francisco. You made mention of that, but they account for just a little over 6% of the population. What is the city doing to reach this community?
Thank you, Director Pappas, for that question. So I think there's a number of ways in which we're sort of thinking about this challenge that we're seeing locally and nationally. The first of which is to really, as my sort of new Office of Overdose Prevention is working towards, is really ensuring that all of our data, all the different drug-related metrics that we are looking at are viewed through a lens of racial equity. So how can we sort of better understand the nature of the crisis through sort of looking at this by race, by ethnicity? And so can we get a better sense of how are sort of the different communities experiencing this? And then what do we do with that information? Really what my hope is with our new office is to share that information as we sort of look to understand the experiences in different communities, in the Black African-American communities, and work with community leaders. Many of individuals who I know are on this call today, I would really welcome the chance to learn from you, to work with you, to think about how can the interventions that we do have here can be best tailored to meet the experiences and the values and the needs of different communities in San Francisco. There is not a one sort of size fits all. And I think it's important that as we sort of think about our interventions from naloxone and treatment on one end, but then also as we think about these larger sort of structural systems issues, how is it that we can bring some resources to bear on addressing these disparities that we do see? So I'm really looking forward to sort of making new partnerships, learning from the community, and really bringing in the resources that we do have, but then also really looking ahead on what are the other strategically, what are the programs and policies that we can do that would also help address disparities.
Listening to you both, it seems like a Herculean task for one city alone to be dealing with. I'm just wondering, because you've brought up the issue of resources, how could state and federal policymakers do more to address the opioid crisis and opioid deaths? Are they doing anything to help support your efforts, both either on the street or through the Department of Public Health?
Mary Ellen, would you like to start with that question?
I mean, I think that we could do a whole session on this. I'll just say in general, a lot of the issues that we see on the street is absolutely a negligence on the part of the federal government. And the issues that we have in San Francisco, I'm not going to throw the state of California under the bus right now, but I will say that we do have a regional issue, right? So from a street perspective, and I know this is a problem. It's interesting. I am born and raised in Philadelphia, but have made my home here in San Francisco for 30 years. But so we're like backwards. But that in Philadelphia has a similar sort of magnet effect. I think that we take on a lot of the responsibility as a region for a lot of these problems. And so that is an issue that we deal with all the time. And that as a city, we want to, and I think that we will always continue to provide the highest level of care and services to people, and we will not put up barriers, but it does become very difficult and overwhelming when we as a relatively small city in a large region are taking on the majority of the responsibility for that, and people are naturally going to go where the services are. So, you know, and then housing is a whole other issue, of course, that is problematic. I guess the final thing that I would say is that the sale, you know, the sort of commerce part of our drug crisis is something that isn't my area, but clearly, you know, we're dealing with like international drug cartels and rings and that sort of thing. And so from that perspective, I think that we could use more help with these are problems that go beyond San Francisco. In many ways, we're trying to deal with what we have in front of us. And without engaging the federal government, having the support from the state, and having a regional approach to these problems is going to continue to make our job very difficult.
Thanks, Marilyn. The one thing I would sort of add is I agree with a lot of what Director Carroll just mentioned there. The one thing I would just sort of add is that our third strategic area is this idea of a whole city approach, recognizing that this crisis is certainly larger than any one office, than one department. It really is an all hands on deck effort, and that's really why I value the partnerships that we do have across the city with our community partners, our other sort of city agencies, and certainly working with DEM, and then going beyond the city as well, is really engaging our state and federal partners, because there is so much to be done, as Director Carroll mentioned. And so I think it's really is a team effort, and I value that, and think there just needs to be more support given from higher levels as well.
So many more questions, but I'm going to honor your time because I know you both have commitments at this point. I'd like to just close with one question. How can communities of faith and our Interfaith Council be more supportive of your work on this particular issue?
I mean, I would just say that we to lead with love, to understand that people are suffering and are sick, and that to not give up. And part of what I would say is, and what I wanted to say about calling 911 and calling in services, don't stop. I know it can be frustrating, but as we've seen tragically recently, the frustration that a person had was taken out on someone who is very ill on the street, and that we cannot have. So we cannot have that happen. And so, please hold us accountable. Keep calling. Contact me directly if you don't feel like you're getting the services. Take it out on us, not on the people in the street who are, in this state, is what I would say.
And I would build upon that too. I think that maybe the two things that I would really sort of encourage you to sort of think about and to engage with us, both of us, in terms of our roles in the city here. The first of which is coming back to that idea of love. One of the biggest barriers that I see locally and nationally in terms of addressing this is just the profound stigma that surrounds individuals who have a substance use disorder or who are struggling and experiencing homelessness. And what that does is it makes, there's only sort of limited ability for our programs or our policies to have an impact if the stigma that individuals feel is deeply internalized. That might decrease their interest in seeking treatment, in seeking services. And the more that we can provide the support, the understanding around this issue to individuals who may be struggling, who may be in crisis, I think that is one way we will really make a difference, is by reducing the collective stigma that exists around this challenge. Because really, for many individuals with severe substance use disorders, they're not using necessarily to feel high. They're using not to feel sick because of just the illness and feeling withdrawal, or just coping with various trauma that they've experienced. It's very, very challenging. And so if we can sort of come back to that theme that came up earlier around love and supporting individuals, that to me is absolutely key. And then the second thing I would say is please reach out, please engage with us. I again will say that I value these partnerships so much, and want to hear from you, want to learn how you're experiencing this crisis and what solutions you feel could be most effective and tailored in your communities, and how can we support you in that work.
In that spirit, and I know that I'm looking at Mary Ellen, and I know you should be on a Zoom right now. I just want to say, number one, thank you for being with us. Number two, we will share with you both the chat today. There were a number of questions, and we asked that if you have a moment to please get back to these good people who asked them. We started with this arc of talking about love, and thank you for bringing it home today in your closing remarks. I would just say that one of the things we do every year is we co-host a memorial for people who have died on the streets, and the numbers are very high. And Listening to you both today and listening to Marvin, I just was wondering how many people of those, were part of the statistics you shared. We are here not just to pray, that we do, but also to be part of the solution. And in inviting you here today, thank you for helping us to build understanding, but also we invite you to engage with us in the future. With that, we bring today's program to a close. Stay tuned for future programming, and thank you for being here. God bless and God keep.